Okay, perfect. So hi guys, thanks everybody for coming. Like they said, I'm Anna, I'm an M4. I'm applying to orthopedic surgery this year. And so I kind of wanted to give this talk because I'm very interested in orthopedic oncology, but also it's the beginning of school year. So I'm assuming you guys like M1s and M2s. Yes, interested in ortho. Perfect. So kind of just introduce you guys to ortho. This is a very specific field within ortho that is not as common as the other big ones you see, like joints, trauma, spine. So I wanted to introduce you guys to it earlier on. So here we go. So agenda for today. So I'm going to teach you guys a little bit about ortho-onc, just a brief review of primary metastatic bone tumors, then talk about path fractures, how we treat them in adults and kids, and then brief introduction to the field of orthopedic surgery, how you guys can get involved at OSU. So orthopedic surgery, if you're here, you probably know what it is, but we diagnose and treat all conditions of the musculoskeletal system. That's bones, ligaments, tendons, muscles, nerves, cartilage. And there's a lot of different subspecialties within it. So like I said, I'm applying ortho. I was kind of a late addition to ortho. I decided to do it February of M3. So it's possible to start later, but luckily you guys are all here as M1s and M2s getting involved early. That said, you have a lot of opportunities to do ortho at OSU. I'll explain it more at the end. But for me, I rotated as an M3 on joints and trauma, really loved it, decided to do ortho. And then from there, ended up doing onc for my sub-I as an M4. So that's where I kind of found onc. It's like my main passion within ortho, made a lot of sense for me. And same thing, I got to do some pediatric orthopedic surgery. Loved that too. So I'm now in a month over at Children's with Dr. Scharschmidt. He is the pediatric orthopedic oncologist over there, and spending a month doing that. So orthopedic oncology itself, it's the treatment of benign and malignant, both bone and soft tissue tumors, and it's surgical treatment of cancer patients. So we do co-management with med-onc and with rad-onc. You also do inpatient medical management when your patients are admitted. So unlike kind of the rest of ortho where you can kind of throw out the medicine knowledge, you still retain a bit of it if you're doing ortho-onc. And notably too, as far as the med-onc, rad-onc piece, you'll see most surgical specialties for oncology are using med-onc and rad-onc for all of the management that's medical. The only one where you're not going to see that is gyn-onc. They manage their own chemo. I think it's for the better for us in ortho-onc that we don't. Definitely the expertise is over on the med-onc side, and then we kind of just follow along. And we see the patients for their surgical concerns, but after the fact for the chemo and radiation, they're seeing those doctors. And I think it helps to take some of the emotional burden off of us. Other things with ortho-onc, so super innovative and high-tech field. When you're doing big cases, so like the hemipelvectomies are like the 12 to 18-hour ones, distal femoral replacements, we use really cool implants. So for example, these ones here are some custom implants in a pediatric patient. And then we also use like intra-op navigation. So lots of cool things if you're interested in engineering and technology. And then we also do bread and butter surgeries. So bread and butter for us looks a lot different than the other orthopedic subspecialties because it's a wide variety, but you do arthroplasty, so joint replacements, and you're also going to do like intramedullary nails for your fractures. And then you can also do benign soft tissue tumor resections. But the main focus now for orthopedic oncology is limb salvage and reconstruction. Years ago, what they were doing was a lot of amputations. So patients that came in with like osteosarcoma at their knee were going to get an above knee amputation. Nowadays, we do a lot of limb reconstruction. With that, you have aspects within your practice of arthroplasty, so doing a lot of hip and knee replacements, also amputations on occasion, and then Dr. Scharschmidt over at Children's does amputations for children with conditions, for example, like caudal regression syndrome, which are kids whose legs don't function. And so it's better for them to get amputations. So he handles that over there too. And then you can also see spine for ortho-onc and then elements of trauma surgery. Other benefits, if you like bio, big understanding of cancer bio as compared to other orthopedic fields. You need familiarity with the med and rad-onc, but you don't have to be experts. And then you retain the medical management skills. And then there's a really diverse breadth of practice. So something I really enjoy about it, you get to see adults, you can do kids, you can do the entire musculoskeletal system, which is quite different than your subspecialized ortho fields. And it's very rewarding. So caring for cancer patients, they're very, very appreciative. They tend to have really good outcomes, especially for like relative to other types of cancer. And you have longitudinal relationships. These are patients that you're going to be seeing and follow up for years and years after you take care of them. And then multidisciplinary, like I said, med-onc, rad-onc, but we also do a lot with plastic surgery. So orthoplastics is huge. And then also surg-onc, especially for the hemipelvectomy cases, and then path. And Creativity-wise, each case is very different. It's cancer, so you have a lot of surgical planning that you do pre-op. You also have implant design and a lot of opportunities for creativity within ortho. It's a very academic field, as you can imagine. Most of them are based out of academic centers, especially those that have comprehensive cancer centers like OSU and the James. But you have opportunities for bench and translational research if you're into that. And then there's a good mix of traditional orthopedic surgery cases, which would be like bone, if you will, versus the soft tissue sarcoma cases. So brief overview, primary versus metastatic tumors. A primary tumor is one that started in the bone or soft tissue. So that's like your osteosarcoma, your chondrosarcoma. Whereas a metastatic tumor is one that is a metastatic lesion that is secondary to another type of cancer. So for example, it would be a lesion that was secondary to metastatic prostate cancer. As far as benign bone tumors go, we see a lot of these, especially in kids. You can, for the most part, watch these and observe them, but there are situations where you're going to do surgery on them, for example, if the patient has pain, and then also if you end up having a fracture. So osteochondroma is the upper left corner photo. These are like displaced nets of cartilage. If you look at it, you can see the kind of stalk coming off of it. You can see if my cursor wants to go over there. So here's like the stalk, and then you have the tumor coming off of it, and it's just a displaced nest of cartilage. Usually around the growth plates in kids, they're painless for the most part, but when they get really big, you'll end up taking them out. So we had one last week at Children's that was quite large, and it was causing the patient a lot of pain, so we ended up doing a resection. Enchondromas, also cartilage tumors, but these ones are inside of the bone, and they don't disrupt the cortices. And you can see the like stippling and calcifications on the inside. Next one's a non-ossifying fibroma. So these ones are eccentric tumors, tend to be in kids. They have like a bubbly, it's like soap bubble appearance. And on histology, you'll see spindle cells. And these ones end up ossifying with age. So usually you can just watch and wait. Simple bone cysts. So simple bone cysts, it's a cystic, like lytic lesion at the metaphysis. They do expand through the cortex, at which point, if you see how large this one is, you're going to end up probably doing surgery on it just because the patient can have pain because it's expanding. Also, you can tend to have fractures. When you have a lesion that large, your bone gets very weak in that area and fractures are not uncommon. So surgical treatment for those. And then osteoid osteioma is the next one over. It's kind of hard to see the lesion, but it's the tiny gray one on the left. These ones are in kids. You're going to see pain at night. But the big thing, what differentiates it between a malignant tumor, which also has pain at night, is that with an osteoid osteoma, you can give them NSAIDs and it'll cure their pain. And then these ones resolve with age too. And then last is the giant cell tumor on the right. Giant cell tumors, they're lytic lesions, so you can see like that gray circle. They're well defined, but they're also very destructive, aggressive, grow very large. So you're going to treat those with surgery. And then the three malignant ones that I'm going to go over. So osteosarcoma, you guys are probably familiar with. It's bone-forming tumor. The lesion's going to destroy the cortex, so it goes right through. Tend to see it in adolescents and young adults, commonly going to be at the knee, whether that's going to be the distal femur or the proximal tibia. And then they're quite aggressive. You need to do surgery and a lot of chemo for these kids. And then Ewing sarcoma, so that's the next one over. Tend to be on the shaft of long bones. It's more subtle than the osteosarcomas. The osteosarcomas, they tend to see like a sunburst pattern. The Ewing sarcoma is a periosteal reaction. They call it like an onion skinning. So you can see it just laterally to the cortices. And for that, surgery and chemo as well. It's also adolescents. And then finally, the chondrosarcomas. Chondrosarcomas are different because they're mostly seen in adults. Those are 40 to 60-year-olds. It's a cartilage tumor. You're going to surgically resect it, and then it will also extend beyond the cortex. And then metastatic bone tumors. So these are like your secondary bone tumors. Metastatic lesions of bone, secondary to a primary. More commonly, this is what you're going to see in an adult. If you see a malignant bone tumor, it's probably metastatic, much more common than primary bone lesions as far as the adult population goes. You'll tend to see them in the axial skeleton, so a lot of spine lesions, also down to the sacrum, more so than the appendicular skeleton or the limbs. But you still will see a lot of metastases to the limbs. We do a lot of nails over at OSU for these patients. And then the most common tumors that are going to metastasize to bone, there is a mnemonic. It's called BLT with a kosher pickle, but it's breast, prostate, thyroid, kidney, lung. That's just how you can remember it. And then lots of other cancers also metastasize to bone. You'll just see those 5 most commonly, and those are the testable ones. So this part of the presentation is how we treat the impending and complete path fractures in adults specifically. And it's going to be case-based. So this is a case we had at OSU. It was year-old male. He had prostate cancer. He'd been referred to us because he had lesions that were found on his right femur and right humerus, and he had a history of metastatic prostate adenocarcinoma. He'd been having worse thigh pain for a few months, both at rest and with ambulation, but he didn't have any arm pain. He had already gotten a good amount of medical therapy for his prostate cancer. He'd had it for over 3 years, and then he had radiation done. It was salvage radiation back as well as the prostatectomy, but no orthopedic surgeries. And as far as physical exam goes, for patients like this one, he had an impending path fracture. So for exam, you want to be gentle because if you are doing a lot of manipulation, you have the risk of fracturing their bone. So tend to not do a ton of range of motion there, which is why we deferred his hip range of motion. But otherwise, he was intact for sensation and pulses. And then his right upper extremity, his right humerus was completely fine. Imaging-wise, he had an X-ray and a PET scan done, and he had not had a biopsy. So here's his imaging. These are his X-rays from, you can see like on the left side, so that's his right femur. You can see kind of the circular lesion that's gray up towards the head of the femur. It's large and lytic, and it's the posterior intertroch region. So the second photo, you can kind of get a better idea of how it's the posterior intertroch. And on the right side of it, that's his humerus. This one's more difficult to see as far as lesions go because it was blastic and lytic. So if you have a blastic lesion, it's osteoblasts that are creating too much bone versus lytic, which is osteoclasts breaking down too much bone or an inhibition of the osteoblasts. So as you can see, like there are some dark areas and some light areas. So overall, the microarchitecture of the bone is not good. Lytic lesions do tend to fracture more because the bone is weak, but at the same time, a blastic lesion is also not a good thing. Anytime that you disrupt the architecture of bone, whether it's blastic or lytic, it's not good. And then here's his PET. So PET on the right femur, you can see he had that lesion lighting up, cortical destruction, so it was already through the cortex and the lesser troch. And then on the right, that's his humerus. So humerus actually lighting up a ton, and which you go back and look at how much it kind of spanned the entire humerus. So it makes sense when you look at it on PET. It was just interesting because he didn't have any symptoms from his humerus. And he also had spine metastases, but I didn't show it. So metastatic bone tumors, rule of thumb, if you're over in the adult world at the James and you see a skeletal lesion in a patient and they're over 40 years old, the mnemonic that they use is METS, 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 myeloma, lymphoma. So to remind yourself that it's probably a metastatic cancer. The odds you have a primary cancer are very slim. The workup you're going to do, though, still, you're going to do CT, chest, abdomen, pelvis. You're going to do a whole body bone scan, labs, which are like an SPEP and UPEP, usually from myeloma, and then biopsy. And so any new patient that has a metastatic bone disease needs a biopsy. In the biopsy, I'll show you a photo later, but it'll have like nests and glands adjacent to bone. And it's important because you're trying to determine if it's a metastatic lesion or if it's a primary lesion. Again, multidisciplinary management. And then these patients have inevitable disease progression. So when we have metastatic bone tumors, it's a patient that has metastatic cancer. We are not curing them. It's palliative surgery to make them feel better and to hopefully help improve their quality of life, but does not in any way change the way that their cancer is going to go. So path fractures, by definition, a path fracture is a fracture that arises in bone that's modified from a local or systemic process, such as malignancy, but it can also be other things. So it can be like malignant diseases, infections, neuromuscular pathologies, radiation. For the sake of this talk, when I say a path fracture, I'm talking about path fractures that are secondary to malignancy. And you can see the photos here. So the photo on the left is a lytic lesion of the humerus, but it's an impending path fracture because it hasn't actually fractured yet. And then on the right is a different humerus, but you can see it's already fractured. So that's a complete path fracture. And these occur with very minimal trauma. I've had patients say, like, I rolled over in bed or I just turned my arm a funny way and they broke their arm. So very minimal, and it can be the presenting sign of malignancy for a lot of patients. They'll come in with a fracture and find out that they have metastatic cancer. And so anywhere from 5 to 29% of patients with metastases of the bone end up with a path fracture. Fractures more likely in lytic lesions, like I said. And what we end up using are two sets of criteria. So the Merrill's criteria are used to predict the impending path fracture likelihood that it's going to fracture, and then whether we're going to do something about it. And then Harrington's criteria is specifically the indications for prophylactic fixation in the femur. So Merrill's, you end up looking at the size of the lesion, where it is, if it's blastic or lytic, and then also whether the patient has pain. From there, use the scoring system to decide fracture risk and whether you need to just observe it or if you should be doing prophylactic fixation. And then Harrington's criteria, similar thing. It's just about destruction of the diaphyseal cortices. If you have metaphysis destruction, persistent pain after they've already gotten radiation, and if you have destruction of subtroch femoral of the femur. So treatment options themselves. So first thing you can always do is conservative treatment. You do nothing for the patient. Medical options, you're going to do osteoclast inhibitors. So the bisphosphonates and denosumab are the main ones you'll see. They're also, of course, going to be on systemic therapies for their primary cancer. So usually that's going to be chemotherapy. They might also be on hormone therapy, for example, the patient with prostate cancer, or you can have immunotherapy. And then radiation is pretty big for metastatic bone tumors. So post-op radiation, it's recommended for all patients that have solid tumors or lymphoma after you've fixed the complete or impending path fracture. And you end up starting the radiation like 2 to 4 weeks after surgery, after the wound is healed adequately, because radiation does not help wound healing whatsoever. So you want to make sure they're somewhat healed before you start. You're going to radiate the entire bone. And the benefits of it, you're alleviating pain and slowing progression. Functional status and quality of life are improved, and you decrease the risk of fracture. But like I said, does not change the course of the patient's cancer. And then surgery-wise, you have a lot of options. It depends on where in the body the lesion is, but you can do arthroplasty, so a joint replacement. You can do intramedullary nailing, plate and screw fixation, or also resection. So standard of care for an impending path fracture tends to be initial surgical fixation with radiation afterwards. So for example, for the femur, like in this patient, you have options based on where it is in the femur. So if it's a femoral neck, you can do a hemiarthroplasty. If it's in the shaft, you can do an intramedullary nail. And then if it's intertroch or subtroch, you have the option of either. And indications, like I said, you follow those criteria that I mentioned, but if you have any compromise to the structure of the bone, functional pain and pain after radiation, that's when you're going to want to do surgery. And then goals, like I said, just maximizing their mobility and weight-bearing potential, protecting the bone and optimizing the implant given their prognosis and estimated lifespan. So that's an important one. If you have a patient with metastatic cancer, you need to recognize whether they have like weeks to months left to live, years left to live, and let that guide the implant that you're going to use, and decide whether or not it's worth it to have surgery. Just because the cancer patient already, of course, has a lot of risk factors, they're immunocompromised, is it worth it to put them through a surgery? And then last thing for the intra-op biopsy that you do, because I said you need to get biopsies for all these patients, super important. If you go in and you think it's a metastatic bone lesion, but it actually ends up coming back consistent as a primary neoplasm, you have to close the patient like immediately in the operating room, and then you send them to a sarcoma center if you're not already at one. They're going to get chemo and radiation, and at that point you can consider surgical stabilization for resection. But if you were to keep going with fixation, you're going to contaminate the entire bone with sarcoma. And that kind of goes back to why we radiate the entire bone as well. So if, for example, if you have a metastatic lesion and you're going to put a nail down a humerus or a femur, they already have metastatic cancer. If you're spreading those cancer cells further throughout the bone, totally fine. It's already there. It's already in the blood. You're not really harming them more. And then you're going to radiate the entire bone to kill those cells. If they have a primary neoplasm and you try to shove a nail down, you're spreading all of that cancer to the rest of the bone where it hadn't spread yet. And so you have a whole new problem. And most of the time with the primary cancers, we end up trying to do very wide radical resections for these patients where ideally when you're in surgery, you never even see the tumor. You do not want to see it a single time before you take it out. So if you were to put a nail down, you're really contaminating the entire thigh, the entire arm. And then photos for treatment options, if you guys are not familiar. So up on the left side, these are hips, these are arthroplasty. So the top one is a total hip. So you can see there's the femoral component and then also the acetabular component. The difference between that and the hemiarthroplasty, which is at the bottom, is that a hemi still has the femoral component and it has the femoral head on it, but you do not have an acetabular component. So essentially your articulation is between a native acetabulum and then the metal of the femoral head implant. Therefore, a hemiarthroplasty tends to be better for older patients, patients that are less active, don't like walk as much, just because you're going to be wearing down that native bone much faster. Second thing, this is ORIF, so this is plates and screws that you can use to do for a fracture. And then third thing is what a nail looks like. So this is an intramedullary nail. You can have long nails and short nails depending on where the fracture is. This one's fracture, as you guys can see, is pretty far down the femur. So you do a long nail there. And then this is just showing you the construct of what it looks like in the bone. And so prophylactic fixation, kind of the why that we do it, because sometimes I think patients are like, I don't have a fracture yet, why are we doing surgery? It improves your survival overall. It's much, much easier to do surgery on a patient who has not fractured yet than one that already has a fracture. The surgery is less complicated, takes less time operatively. They have a much faster and quicker recovery. And then you avoid other harms. So these cancer patients, it would be bad if they fractured. They would be hospitalized. They would probably have to pause their chemo or systemic therapy. So we try to avoid that by fixing it before it happens. And then, like I said, palliative surgery, goal is for the fixation to outlast their survival. It's in no way or shape or form going to change the outlook of their disease. So for our patient, we ended up doing a prophylactic fixation for his impending path fracture with a cephalomedullary nail. This is a long nail. You can't tell because it's just the top of the photo. But we did an intra-op biopsy. It was consistent with his metastatic prostate carcinoma, so that's why we did the nail. Post-op radiation for him was going to be at 3 to 4 weeks, and then overall he was doing well. The photo on the bottom is just an example of what you would see during path. So it's just the metastatic cancer, and you can see like the nests and glands on there. But the nice thing, so when you're an M1 to M4, you can do a lot. Actually, at OSU, we're a very surgery-heavy med school. So if you, once you're an M3, they're going to let you do a lot in the OR. But once you're an M4, like for this one, that's a nail that I got to do by myself with Dr. Alexander. So you have a lot of freedom once they trust you, and once you get to be an M4 to get really hands-on. So next section is the path fractures kids. The case here, so this was a 9-year-old that had a complete fracture. He had alveolar rhabdomyosarcoma. Kind of disclaimer for him, he had a very poor prognosis when he came in to see us. So he was looking at like weeks to months left to live. He had come to, and they had kind of concern for a hip fracture. They said he'd been walking down the stairs and he just started having pain in his hip after walking down. Couldn't really move his leg. So he came to his normal appointment. They were very concerned, admitted him, sent him to us. He had a fracture of his femur. So history-wise, metastatic alveolar rhabdomyosarcoma. We'll talk a little bit more about rhabdomyosarcoma, but his primary location was his left tibia. He also had metastases already to the left iliac wing. He had had radiation for that left iliac wing, and he'd had several rounds of chemotherapy, but he hadn't had any actual surgery for his rhabdomyosarcoma. Physical exam, same thing. Like I said, we try not to manipulate them that much if they are already fractured. So he had a left lower extremity exam that had severe tenderness palpation, but we didn't do anything as far as range of motion. And then his diagnosis was a path fracture that was an intertroch femur fracture. So the one interesting thing for him was we were uncertain whether this was a path fracture that was secondary to radiation or if it was secondary to a lesion. So both of those by definition are still path fractures. Like I said, radiation damages the bone and can be something that can cause pathologic fractures. But it can be malignant, secondary to malignancy versus secondary to the radiation in this patient's case. So here's the imaging. So you can see on his left femur, probably won't be able to get it, but somewhere over here, you can see that's where his fracture line is. So it's through the intertroch region. And then you can kind of see it better on the frog leg, which is the second photo. But it was basocervical region and then down into the intertroch. And he did not have any obvious lesion. So that led us to believe that it was probably secondary to radiation. And so pediatric bone tumors, very different game than adult bone tumors. For peds, primary bone tumors are what you're going to see the most. Way more common than metastatic bone tumors. Metastatic tumors, if you do see them, likely neuroblastoma, but again, way less common than the primaries. So your primaries are like your osteosarcoma, Ewing's, chondrosarcoma, and then kind of the less common ones you'll still see. So the malignant fibrous histiocytoma and adamantinomas. And then demographics-wise, they are slightly more common in males, so it's only 1.2 to 1, but the tumor site's then going to be usually the long bones of the lower extremities, so you tend to see these around the knee. And this little diagram here is from first aid. It is showing you kind of where you can see those common lesions, both benign and malignant ones, but the diaphysis, the shaft, you have like the Ewing sarcoma up there, and the round cell lesions, and the osteodosteomas. Down to the metaphysis is where you're going to get your osteosarcoma. You can see they're doing a good job showing you how it's invading the cortex. You also get osteochondromas there, and then at the epiphysis is where you get the giant cells. And so another thing with PEDS tumors, they're really diagnostically challenging. The symptoms that they're going to present with are just pain, swelling. They might have a palpable mass. That overlaps with a lot of common benign pediatric conditions. So for example, like a lot of kids are just very active. They get a lot of bumps and bruises all the time. It's like they were just playing soccer all the time, they fell off their bike, maybe they're just growing pains. So it takes a lot longer for them to actually make it into clinic. And by the time that they do, if they have something like osteosarcoma, it can become pretty advanced and the prognosis gets worse. So for osteosarcoma specifically, 50% of those patients have a preceding trauma, which brings them into clinic. And then suspicion of malignancy is pretty low. So for osteosarcoma, only 31% of patients, and for Ewing's, only 19% at the first visit that they came, did anyone have any suspicion that they actually had malignant cancer. And then poor prognosis, you guys probably are aware of this, but osteosarcoma has a really poor prognosis if it is metastatic at presentation. So it's 10 to 30%. Somewhat decent, 75% if you catch it before it metastasizes. But they overall, it's tough for the osteosarcoma kids, and you tend to see, even if you have a perfect wide resection and get rid of the entire cancer, it can still metastasize to the lungs. So it can be really devastating. You can have kids that come back with like bilateral osteosarcoma. Okay. And so then pediatric soft tissue sarcomas, I didn't talk much about the soft tissue tumors earlier, and this is kind of the extent that we'll talk about them, but it's relevant because the patient case, he had thoracic So there's two histologic types. It's embryonal and alveolar. Alveolar, it's named that because it actually looks like lung tissue. But these are small round blue cell tumors, usually in kids less than 14. And they're usually going to be in the extremities or the head or the neck. So for example, our patient, his primary lesion was in his tibia. Same thing with other bone tumors, so painless mass, but once it's cortical bone involvement, you're gonna have pain with the weight bearing. And then workup is similar to adults. So it's biopsy, you're gonna stage with a CT, chest, abdomen, pelvis, do bone scan, and then bone marrow aspirates. And treatment-wise, so surgery, you're gonna do a wide complete resection, you're gonna do radiation and adjuvant chemo. And then the other options or the other types are the non-rhabdos, more common in adolescents and adults, so not so much in peds, but you're going to see like the fibrosarcomas, the Kaposi sarcomas, the other specified, which like the common ones you'd see are like angiosarcoma, liposarcoma, leiomyosarcoma, and then unspecified. And then specifically for the pediatric path fractures, etiology of it is different than the adults. So a lot of the time it's actually secondary to benign tumors. So kind of like I was showing you earlier, that simple bone cyst that grows to be really large, it's benign, but when it gets that big, it's lytic and it's making the bone weaker. You end up having path fractures. You see the same thing with the non-ossifying fibromas, chondroblastomas, and chondromas. And then rarely is it going to be secondary to malignant process or a tumor, but if it is, it's the same thing. It's Ewing's, it's osteosarcoma, leukemia and lymphoma as well, and then the metastatic tumors or radiation. So radiation, the bony change is there. So radiation, it impairs the vasculature. So then you have abnormal osteoclasts, abnormal osteoblast-mediated bone turnover. It changes the entire like microarchitecture of the bone, which then compromises the cortical structure and cause fractures. Bone is usually weaker 2 to 3 months after they've done radiation, and fracture risk is dependent on the dose that's delivered, where you're doing it, how old the patient is. But anywhere like 20% of the irradiated sites can end up having a path fracture at some point in time, so the risk is high. And the path fractures in irradiated bone have an increased risk of non-union. So with bone healing after fractures, you can have malunion or non-union. Malunion is where it starts to heal, but it doesn't heal in proper alignment. Non-union is where it does not heal at all. And then you can also have delayed union or infection. And then radiation, it results in the prolonged healing times. It's really bad for wound healing. And then treatment-wise, generally you're going to treat path fractures that are secondary to radiation with a nail, depending on where it is in the body. But you can also do ORIF, which is like plates and screws. You can use iliac crest or fibular grafting. And then indications are similar to the adult. You use Murrell's and Harrington's criteria. And so treatment of path fractures in kids, it's different than adults. So you'll hear a lot of the time, like kids are not just small adults. And that's especially true in ortho. Kids, as you guys know, are growing. They are going to have growth plates that are open until they're teenagers. And so when they have fractures, especially those that go through their growth plates, there's a big concern for growth arrest of those bones. And so that's something to be cautious of and something to be mindful of when you're deciding how you're going to treat a path fracture. So first thing you're going to do, you're going to establish priority. So treat the underlying disease or the fracture first. If it's a benign lesion, you just fix the fracture. If it's a malignant lesion, you're going to treat the causal disease first. So probably have them go through their chemo radiation if they need before you treat it. Next, biopsy the lesion. It's either percutaneous or open surgical biopsy. Same thing, possibility of seeding the bone is always there, so be careful. And then treating the path fracture. For a primary, it's different than a secondary. So primary, you're going to do primary, so those are the ones like your osteosarcomas. Those were traditionally always just treated with amputation. You had a lot of kids that were getting above knee amputations. Now we do limb salvage surgery with negative margins, and I have more on it in the next slide. But that's what we're doing nowadays, working on limb reconstruction and lengthening. And then the initial fracture stabilization, you're going to do kind of what you would do in the ED normally. So for a kid, it's going to be a cast. If you have to, it would be traction or X-fix. From there, you're going to get a biopsy, do chemo, and then you're going to do surgical resection and fracture fixation. Whereas the secondary ones, so your metastatic lesions, for those ones, they're rare in children. Like I said, it's probably going to be neuroblastoma if you do see it, but for those, you're still going to biopsy it, and treatment is palliative, meaning it's similar to the adults. You're going to do just a surgery, for example, like a nail, or you can do an arthroplasty, whatever it needs to be in order to stabilize the fracture. And then benign lesions, they're not super concerning, so you can just treat them however you see best. Casting in kids, we do all the time. Kids' bones heal extraordinarily well, so the vast majority of things you're going to do surgery on in an adult, you're going to just cast for a kid and they'll come back completely fine. You can surgically stabilize if need be, and then if you have a suspicious lesion, you should still be biopsying it. And then next thing is just for surgical treatment for the primaries, it's limb salvage versus amputation. And so limb salvage, what we do now, this is what they do over at Children's. So this patient, this is a patient that's a children's patient. They had osteosarcoma bilaterally. They had it 2 different times. So they had the first one in the right side, went through chemo, radiation and everything for that. And then 2 years later, ended up with osteosarcoma on the left side. So had to re-go through the entire process. But what that patient ended up getting was Stanmore implants. So these are expandable, like extendable implants. They can grow with the patient over time. This patient had osteosarcoma at like age 6. So they had a lot of growing left to do. And so these implants are awesome because you go in and you do the like radical tumor resection in surgery, and you put these implants in place of like a standard type of total joint. You'll use these instead. And then from there, the lengthening actually happens just in clinic. So they don't have to have surgery again. The little machine that you can see on the left is like it uses magnetism to lengthen the leg. And so you just do a couple of millimeters like every office visit that they come in, so that you make sure that the one limb is growing equally to the normal side. And so for patient outcome, for our patient with the rhabdomyosarcoma and the fracture, this one was interesting just because, like I said, he had a really poor prognosis, only a couple weeks to months when they came in. So we had to have a lot of discussions about the utility of surgery and whether it was worth it. They ended up choosing to do surgery just because he was in a lot of pain. They wanted him to be able to move and walk around like a normal kid. But he had higher risks than other children. For example, he had radiation, so he had poor bone quality. He's going to have slower healing. Avascular necrosis is always a risk, especially when you're going into the femoral head in kids, and then possible need for additional surgery. But procedure-wise, what we did, clearly you can see it's different than adults. We did percutaneous fixation with 3 partially threaded cannulated screws, and you place them in an inverted triangle pattern. And then here's more photos. The left photo is intra-op fluoro, and then the 2 photos on the right are what his hip looked like at his 1-week post-op visit. And overall, he was doing well. He was like able to weight bear on it. And so far, he's been doing great. So last bit of the presentation is just about orthopedic surgery, kind of considerations for the specialty and applying. So orthopedic surgery residency, 5 years. You can make it 6 years if you want to do a lot of research. You can have then 1 year of fellowship. You can be a general orthopedic surgeon and not do a fellowship, but it's relatively uncommon these days, and most people will go and do at least 1 fellowship. Subspecialties for fellowships are all written on the side. You have a lot of options. Career-wise, it's a highly outpatient surgical specialty. When you're in residency, of course, you're doing a lot of trauma, so you're in the hospital a lot. But once you're in attending, most of the time, you have a great control over your schedule. So it lends itself to a good work-life balance. And then you have mix of surgery clinic and then private practice versus academic versus hospital employed. And AAMC says 53 hours a week for attendings and median salary is $686, but I don't know if we trust that or not. And then some match statistics, you guys probably know this, really competitive specialty. There are 208 programs right now, which is actually really good for a surgical specialty. It's nice we have a mix of academic and community programs. So academic obviously is like your OSU, but community programs, we have one in Columbus, it's Mount Carmel. They just have a lot less focus on research. And so if you, for example, really know that you want to do private practice, community programs are a really great option for you. And also if you just don't have a lot of research going into the application cycle. Stats-wise, probably doesn't mean much to you guys right now, but Average step 2 is a 257, which is really high. Median number of research items is 14. So that's actually not terrible. But median number of research items means anything from publications, abstracts, poster presentations, oral presentations, all of those count. And then last year, the match rate for US MD seniors was 68%. So for first-time fourth-year applicants. And then we don't really have many girls in the room, but 20 to 30% of the current trainees, like the residents and fellows, are female. Only 6% of practicing surgeons are female, but of course that's increasing. And then as far as the actual application cycle goes, what you can like prepare for when you're going into M4, you're going to do a home sub-I. You're then going to do 3 away rotations at least. That might increase by the time you guys are applying. And then when it's time to submit your ERAS application, you're going to have 30 program signals. We do in-person interviews actually. So for the months of December to February, you're flying around the country, and then match in March. So my recommendations for M1s and M2s, number one most important thing is doing well in school. There is nothing that is going to beat good grades. You cannot do more research, you cannot do more activities and think that's going to overcome bad grades. It just doesn't work like that. Shadow in your free time if you can. We have the OSIG, like orthopedic surgery mentorship cohort you can apply to. It essentially pairs you one-on-one with an orthopedic surgery resident at OSU. And over the course of the year, you go to clinic in the OR with them and you end up seeing all the different subspecialties. Also recommend participating in MDSR or any other summer research program we offer to just get started in research. And the MDSR program is like a very structured way to get into research. You learn how to do a proposal, sometimes doing like an IRB, you do all the data collection, write a manuscript. And then as far as getting started with research, I personally would say like recommend if you want to start early, it would be second semester of M1. If you are feeling very comfortable with school and the workload, you can do it earlier than that. But I think it's probably best to just get off on the right foot with your schoolwork first and then start research. Definitely, like, there are mixed reviews on how much research you should be doing. I would say probably try to cap it at like 10 hours a week. If it gets to be more than that, you will end up, your grades will fall. And I've seen that happen to enough people. And you just don't want that to happen. It kind of eliminates your ability to even apply. So grades first. And then pay attention to the preclinical blocks that you enjoy the most, and please explore other specialties too. I was a person that was undecided for most of med school. So I think it helped actually in that when I was a third year, I approached every rotation with an open mind of like, am I going to do this? I could actually end up liking it. And so I enjoyed them a lot more, I think, than if I was just focused on knowing I was just doing ortho. So keep an open mind. A lot of people end up changing their minds as well. And then start your CV now. You're going to be asked for your CV like constantly over and over again. So just keep it up to date, just constantly update it, and it'll be easier that way. And then for M3s, 2 chances to rotate for ortho. You do 2 weeks, either during surgery ring or the FM ring. When I was on surgery, everybody wanted to do ortho, so I only got to do 2 weeks during my FM ring. That was enough. And then come to the OSIG events. We have away rotation panels, post-match panels. I think we're going to try to do more for you guys this year as far as like sub-I preparation and just some other stuff so you can talk to the M4s and get a better idea of what the application cycle is like. Reach out to the current M4s. There are 15 of us applying, so there's plenty of people to talk to. If you're undecided, I would say try to choose to do ortho like at the absolute latest by March of your third year. I said I did it in February. That was very last minute. So I would say try to figure it out by like January, February if you can, and definitely focus on increasing your research productivity. Just get your numbers up in any way you can. You can consider a research year if necessary. Our ortho department tends to shy away from research years and have us just apply. But if you have like 0 research items for research year, it could be good. And it's also a good networking opportunity. And then, like I said earlier, grades are the most important. Do well on M3. And doing well on M3 helps you do really well on step 2 also. And then networking, get to know OSU's department, the faculty, the residents. And then Dr. Putnam is our new med student advisor for ortho. So you can meet with her as well. And then once you're in M3, you can shadow, but you can also take overnight call with the residents. So I never did this as an M3, but it was something like Dr. Speakart recommended we do. So if you have free time and once the away rotation season is over for the M4s, you can go and do call on the weekends with the residents and see what it's like. And then away rotations wise, you have to start thinking about them by winter break because you're applying for these January to March, and a lot of ortho aways are like a first come, first serve situation. So you want to have your application ready to go by early January. And the big thing too with the away rotations, the way it's trending for ortho is that you're most likely to match at a place where you did an away. So you have to be really mindful about where you're doing your aways and choose the places you want to match at the most. And then my last thing is don't forget about children's. No one ever goes to children's for ortho. I am doing my month elective over there right now with Dr. Scharschmidt, and they said I was the first M4 to ever come over to children's. So I would highly recommend you do it. It's awesome. You can shadow there if you want. The attendings are all awesome. They do a ton of research if you want to do research. They have dedicated research fellows who are in research years. So for them, like the entire goal is productivity. So definitely you can reach out to those research fellows. And then you can take call with the OSU residents because at any given point in time, there's at least 3 OSU residents on, if not 4. So it's a great opportunity to just get to know people in OSU's department as well. And then last thing for the girls, ortho is like historically a very male dominated field, which is totally okay. But we also have a ton of females at OSU specifically. We have a lot of female faculty in all the different subspecialties, which is great. We have a ton of female residents as well. So I would say just reach out to the faculty members, to M3s and M4s. We have 6 girls applying ortho this year. So reach out to any of us. And then you can attend the events that we have. So we have like the Perry Initiative events, which are like the Sawbones events. And then the Ruth Jackson Orthopedic Society is the female orthopedic society. So we also do stuff there. Dr. Putnam and Dr. Goyle have put on like hand workshops for us where we do surgery simulations with cadavers. And male med students are allowed to come to the female stuff too. But yeah, so references. Thank you guys for coming. And then if you have any questions, it can be about the presentation and onc, or it can be just ortho, med school, anything. Yes.